Hi, Dr. Coleman.
Hi, how are you? It's good to see you.
Good, how are you doing?
Doing great, doing great. I'm sitting here in my studio here, or my library, and getting ready to have a chat with you. I just wanted to let you know I brought my patient quilt with me, which has these inspiring verses. I always have it here in my office so I can try to come up with some new great thoughts. So I'm gonna put that on my chair. And now I'm ready.
Amazing. Thank you. So, we'll just delve right in because of all this happening. All of us are a little anxious and we are, we don't have all the answers. So for our patients in our community with this COVID-19 thing on top of our minds, as we all navigate through this uncharted territory, what advice would you give to our overcomers in terms of just reducing their risk and staying aware of what's going on?
Yeah, I think we're basically instructing all of our patients to follow the CDC guidelines, social distancing. I think all of the things that we've kind of our personal hygiene type of practices that we would normally recommend for anybody who's on chemo or just even in follow-up, we would recommend the same now. But I think that our concern is that patients who are on chemotherapy, who do get COVID, who come down with an infection, they actually have higher risk. So we really want to prevent the potential for an infection in a cancer patient, and certainly one that's on chemotherapy. So we are telling all of our patients to essentially heed all the CDC warnings. With regard to actual being on treatment, coming in for the treatments, we have been trying to do some virtual visits as much as we can. For patients that are getting intravenous chemotherapy, we have some very important measures put in place to help reduce the risk of coming into the facility. We're actually trying to get people to get their chemotherapy in our Houston area locations if possible, because that keeps them even further from the actual hospital and allows them to potentially reduce their risk. We're minimizing traffic in and out of the center. We're minimizing visitors. We're minimizing even the physician staff that don't need to be there. We are keeping them out of the way. So we have actually, at least at the hospital level, have restricted all of the ports of entry, and everybody is being screened. And every day, we're reassessed. So we have a lot of communication coming from the president and our leadership to make sure that everybody's on the same page with regard to that. But from the standpoint of our outpatient visits, we have tried to reschedule those that are not, necessary to have happen during this immediate time period. So people who have cancer history but are on just regular surveillance, we are, if there's a need for a immediate follow-up, we're trying to do that virtually. So we have direct, kind of interactions like we're doing here, phone calls, obviously, and then if there's a need, also local follow-up with the physicians, if it's possible. So lots of things going on, but as far as the patient, we would just continue to determine whether or not they need to do any kind of visiting, check with their physicians and their offices to see if they need to go in for a specific treatment. And in some cases, we're actually entertaining looking at multiple months of oral medications that could be shipped to the patients. So there's lots and lots of different things, but I would just check with their healthcare provider and for their personal risk to follow the CDC guidelines.
That's great, thank you. And so just a quick question on the chemotherapy, right? We have received a few questions from our patients as to whether it's safe to go in for chemotherapy, should that be delayed, or some patients want to do chemo and not delay it. So what is and I understand that every patient is unique, every physician's guidance is unique, right? Given that, what would be your opinion on that? What should we consider when we make this?
Yeah, I think the major thing is to check with their physicians as to whether or not it can be delayed. Obviously, as this is in a very acute and rapidly changing environment, we have delayed some patients' treatments because we want to reduce their interaction with the actual infusion suites. And as I mentioned, we've been moving some of them to peripheral locations if it's possible. So, but it's always going to be a trade-off for a risk benefit, and we think that a week or two delay is probably not a major issue. 3 weeks starts to get into essentially missing a whole cycle, and so so I would just check to make sure to see what the individual policy is. I would think that in areas in Texas we're not as effective, but if you can imagine what it's like in New York, where they just don't even have capacity to take outpatient intravenous chemotherapy infusions, and so every place is going to be a little bit different. But I would say that to expect that there could be some delays, but those delays probably are not going to be very impactful. There are some diseases where chemotherapy is actually vital that it stay on time and sequence, and the provisions will be made for those patients.
And so this is not related to COVID for once, and I know, right? So I saw that there were a few recently revised guidelines from NCCN on the treatment of ovarian cancer, including how they're evaluating the genetic risk. So tell us a little more about that.
Yeah, so the updates came out just recently, and they are, what I would say is that there's two things. So one is that the overall screening guidelines have been updated. ASCO came out with a statement, it's been in publication now, to talk about that. And remember, the majority of this revision has to do with the predictive power or nature of the mutation status of the patient. So in the past, we talked about familial risk, personal risk, and these are factors that are obviously still very important. But because of the availability of PARP inhibitors and numerous different potential indications for PARP inhibitors as early as the frontline setting, the guidelines are meant now to reflect that somatic alterations, which are those alterations that are not present in the germline but are present just in the tumor, that those are now going to become of some consideration. And what happened in the NCCN guidelines is that they also anticipated that the PARP inhibitors that are being filed for approval, which we expect to hear on very soon, that they are now going to be a new option for patients as they go through their frontline therapy. And so the two that are I think are most of interest and of relevant to us are the PARP inhibitors, olaparib and niraparib, because they were both studied in a situation that includes all comers, all patient population without restriction to biomarkers, and we expect that we'll hear something from the FDA regarding their approval. So in the guidelines, they've anticipated that this will be a favorable or one that will be biomarker discriminated, and so they're adding in another category. So we have wild type, we have germline, we have somatic, and now the third category was the homologous recombination deficiency. And so patients that have a mutation in their tumor for BRCA1 or 2 will almost always have a high level of homologous recombination deficiency. But there are patients that do not have a mutation in those genes, or they may have a mutation in another gene, who have a tumor which is showing evidence of this homologous recombination deficiency state. And that is going to have some implication as to whether or not these PARP inhibitors would be a good idea in the maintenance setting. So that's what's new in the guidelines. So they're a little ahead of the game because we've only had these reports, we've had the publications, but we haven't had a formal FDA approval for where these will be.
Okay. And for patients on PARP or clinical trials, how does any type of virus, not just COVID-19, so I had to get back to this question again. So, I, so how does any type of virus impact these patients? And are there any specific precautionary measures that they should take for COVID-19 in particular?
So I think viruses are a big category, right? So for everything from Epstein-Barr virus to the flu, right? So it's a big, huge category. The COVID-19 is another form of a coronavirus that we are familiar with. It's novel because it has a unique mutation in its RNA structure, which makes it more impactful to patients today because they're just not used to having had this exposure before. But influenza, is the same thing. And so, we think that the major thing I wanted to emphasize when I first started was that we wanted to make sure that the patients that had cancer, or particularly those that were on immunosuppressive chemotherapy, be very, very diligent in their exposure risk, because we know from the Chinese, from the data that we have from China, that patients who are cancer patients who are infected by COVID-19 have a higher morbidity problem. So they have more sickness and more severe sickness than patients who get the infection who are not cancer patients. So, and that goes to make sense, right? Any kind of immunosuppressive event would certainly make an infection worse, whether it's bacterial or viral. So again, I think, the personal protection devices, social distancing, frequent monitoring. I have a thermometer here that we check our temperature with every twice a day, because as a healthcare provider, we have a lot of exposure. And so those are factors that, we're all trying to take. So again, try not to get infected and just do the best you can. If a patient does become infected, they're going to probably want them in the hospital, mainly to monitor their resolution of the symptomatology and for any potentially adverse events like pulmonary.
For the ovarian cancer treatment, I'm going back to ovarian cancer, so we're going back and forth. So what should our Ovarcomers know about the emerging landscape of ovarian cancer in terms of onset, diagnosis, as well as reoccurrence treatment?
Yeah, so, this...
What's new? Again, what's happening that is new?
Yeah, so this is always a very evolving space. It's great. We can have a conversation every week and have something new that's coming, that's being worked on. So I think that right now, that what we're going to see, the most exciting thing that's going to probably happen in the next month will be these new indications for frontline treatment. So, so newly diagnosed patients will have this opportunity to participate in these new PARP approvals. We expect there to be. And then later in the year or early next year, we'll have a decision also regarding the use of PARP with chemotherapy. So that will be some new material. I think that the other big piece of data that should be coming soon in the fall is the results from the Imagine 50 trial, which is looking at the combination of bevacizumab or anti-VEGF based therapy with immunotherapy. And this will be the first, kind of frontline combination trial like that to report. On the heels of that, there are 3 big international phase 3 trials, which are looking at not only just the combination of PARP, of Bev or anti-angiogenesis drugs with an immunotherapy drug, but also the addition of PARP inhibitor therapy. And so I think that the kind of the frontline space will be kind of rewritten in the next couple of years. Obviously, because of that, in the recurrent space, where a lot of the patients, much more higher number of patients are actually dealing with this disease, we'll be evaluating several new therapies to not only deal with this prior exposure to PARP, and we have several of those trials ongoing, which we're close to closing. Actually, we're very excited about this. Some very good new opportunities for patients, even if they've had a PARP inhibitor before. And so these trials are bringing in, you know, these new kind of opportunities for patients who've been previously exposed, as well as some new therapies. And probably the newest one on the market, that's not on the market, but it's coming in clinical investigation, are the antibody drug conjugates. And there's a couple of them out there, about 4 actually, that are starting to work their way through, but one that's very mature, and that's the mirvetuximab compound. So, you know, again, lots of very cool stuff, many combinations. We're not sure which ones are going to be the most successful, but there's certainly a lot of activity going.
Options for the patients coming up.
Definitely,
right.
definitely.
So
Need coffee. It's coffee chat time.
So I was gonna tell you that we are going to arrange for a virtual happy hour. So you should be joining us with our survivors with your wine glass in hand, right? We should do all of that. Yeah. So, you know, we have talked about this many times before, but I'll still ask, because as with everything else, you know, the PARP inhibitors also keep evolving with time, right? Yeah. So of the primary 3 types that are available today, how should the patients weigh their cost and benefit of these PARP inhibitors, you know, irrespective of which one they sign up for, prior to signing up for this treatment? And what should they know in terms of challenges or the promise of PARP?
Yeah. So you know, when we started talking about how the guidelines have changed, it's taken advantage of what I call the predictive nature. So there's these prognostic and predictive values or factors get confused frequently. And so the importance of the PARP inhibitors now is that these gene alterations have led to a predictive nature for the PARP inhibitors, meaning that if you have this mutation, you're more likely to have a benefit than if you don't have the mutation, okay? Prognostic factors don't work that way. They just show that a group of patients do better or don't do better based on prognostic factors, you know, whatever they are, and there's lots of different ones out there. So what I'll say is that in the purest sense, the one group that we know does the best with a PARP inhibitor from the standpoint of treatment. So in other words, you have a mass, you look at it on a CAT scan, it gets smaller. That kind of effect. The strongest predictor for that is patients that carry a mutation in either the BRCA1/2 genes or one of the other ones that we think are important, like RAD51C and D. So a step down from that is this HRD concept. And earlier this year, we saw data from the Quadra trial, and this was added to the data from the Ariel 2 trial, which was looking at rucaparib, Quadra being niraparib, that basically showed that patients that had just the HRD signature alone were showing response to treatment. Now, whether or not it's better than existing standards, we don't know, because we haven't done that kind of study where we've detailed just the group of patients that have this HRD signature. They seem to have, at least though, as an option for therapy. So one of the questions that, you know, patients should want to know is, like, how much information do you know about my specific tumor? Does it have a mutation? Do I have HRD? You know, where do I fit in that scenario? Because I think when they try to make a decision about whether or not to take a PARP inhibitor under any one of these, you know, kind of circumstances, they'll want to know whether or not they're likely to respond or not. Kind of the gray area is, what about the patients that are biomarker wild type? So they don't have HRD, they don't have a BRCA mutation or one of the other mutations. And in that scenario, if you just isolate that group of patients out, we really don't see a huge impact for the treatment of a PARP inhibitor, because it would make sense that the biology of the cancer doesn't support it. So this is, again, back to that predictive power. So the predictive power is not only anticipating the response, it's also anticipating no response. So it works both ways. All right. And so what I've been advising patients is that if we know that they're truly wild type for those biomarkers, I look for something else, unless it's a combination. And that's one of the things that we're working on, is whether or not we can overcome this inertia.
I like that word. You know, I like that word, right?
Overcome baby. That's right. Where's my shirt? I meant to wear my shirt. Oh my gosh.
That's
Yes.
okay. We'll count on you next time. You know that, so you can do it next time. So my last question, Dr. Coleman, is what would be your parting message for our survivors and overcomers that are listening in today, and they respect and love you so much? So what would you say to them, especially under these circumstances?
Yeah, so I say, my parting words are basically to keep the faith. We're going to get through this acute crisis. It adds to a level of complexity to all of our current situations, but it's something we can navigate. So keep the faith. And also, remember my motto: research cures cancer. So as we get moving on from this, I want to make sure our overcomers think about, when there's a decision to be made about a change in treatment or an alteration in the treatment, that they think about that research aspect, because that's how we got to where we are today. Mm-hmm. And that's how we're going to make it the next big steps in the future. But know that you have a committed group of doctors, nurses, support staff, support groups, everybody working to move this field forward, so that we don't have to have these conversations except just to have coffee and wine.
Or wine. Yes, exactly. Thank you so very much for your time.
Pleasure.
Be well.
Pleasure.
And we'll talk to you again soon. Thank you.
Pleasure. Thank you.